Yes, sir. A very good evening to all the participants. I am Professor Santhosh Kumar Rajamani from Maimar Medical College, Kalegaon, Dabadi, Pune. So today I've been asked to deliver a talk on differential diagnosis of neck swellings for postgraduates. Per se, the differential diagnosis of neck swellings, it's like a sea, it's like literally an ocean, because there are hundreds, if not thousands, of differential diagnoses for each neck swelling. So what I'm going to do is basically give you an outline of how about to go about making a diagnosis of somebody who presents with a neck swelling, firstly. Secondly, I'm going to tell you so many important topics that can come in your theory examination, like thyroglossal cyst and other swellings. So I'm going to talk in broad, and I'm going to talk about two aspects. One is the practical aspect of making a diagnosis of a neck swelling, how to go about making a diagnosis. Second is the theory part of it, on what are the questions that can come in your final examinations, and what are the questions that can come in the Viva examination. Because neck swelling is an important topic, absolutely important topic, definitely asked in the Viva examination, especially if you get a cancer case, if you get some form of malignancy in your final DNB exit examination. You will definitely be asked a lot of questions about neck swellings, and you will be literally tested thoroughly. So it's very important. Also, neck swellings are a bread and butter of our everyday life as a carrier, as an ENT surgeon, right? We see neck swellings almost every day, or every day we see patients with some form of neck swellings. So let's start. So before we begin to understand the neck swellings itself, we have to understand the topology of the neck. I'm not going to go into detailed surgical anatomy, but let me remind you that the neck has got two main muscles. One is trapezius in the back, which forms the part of the posterior triangle, and one is the sternocleidomastoid in the front, which divides the neck into anterior and posterior compartments. So this is what it looks like. The deep layer of cervical fascia splits and encloses the strap muscles. Okay, and then there is a superficial layer which contains the platysma. Now, the platysma muscle is part of a musculo-aponeurotic system called SMAS, superficial musculo-aponeurotic system. So this is nothing but it's a very fancy way of saying that there are muscles which are attached to the very superficial part, that's literally attached to the skin, and they are very superficial. So what you can do is they completely form a layer that covers the neck, especially in the front, and this layer of covering of superficial muscles is called platysma, and it is innervated by marginal mandibular branch of the facial nerve. And interesting thing is that you can make a flap underneath that, what is called subaponeurotic flap. So if you're doing thyroidectomy, whether you're doing tracheostomy, whatever procedure, whether you're doing neck dissection, you can always go underneath that. You can take a flap of skin and muscle, what's called subaponeurotic flap, and you can go about doing the whatever operation you're going to do. So it is very superficial. It cannot be separated from the skin. It's just underneath the skin. So you have to go underneath the platysma, no matter what neck surgery you are going to do. Another two important muscles that play a very important role in the neck. Again, I'm not going to go into details. This is not surgical anatomy class. It's just a recap. Is the digastric muscle, right? Digastric muscle. So the 1B marked here. This picture is taken from Anatomy of the Head and Neck by Time. Atlas of Anatomy of the Head and Neck by Time. These are the credits. So this muscle you see marked as 1B is the posterior belly of the digastric. It takes origin from the incisura mastoidea, and then it comes front, and it is attached to the hyoid bone by a fibrous sling, and then it goes and it then turns into the anterior belly, which is marked by 1A, and it goes and attaches to the digastric ridge, right, near the symphysis mentae on the posterior aspect, right. By two, there are elevations in the mandibular bone where this muscle is attached. So it is strong muscle, so there are elevations in the bone there, and this two anterior and posterior head of digastric, they form a triangle called the submandibular triangle. And the number 2 you are seeing is the stylohyoid muscle, which is taking origin from the styloid process and taking insertion to the lesser horn of the hyoid bone. And the number 3 you are seeing is the mylohyoid muscle, which has a U-shaped origin along the undersurface of the mandible. So this is a very brief recap, right? So even if you don't remember anything, just remember that the digastric muscle forms a V-like structure that is attached to the hyoid bone, and in between that V structure is the submandibular gland, and the triangle called the submandibular triangle. And coming to the anterior aspect of the neck, now very brief recap of the anatomy. There is a muscle that takes origin from the notch of the scapula, near the notch of the scapula, which is called the omohyoid muscle, right? The omohyoid muscle travels upwards and then attaches to the lower border of the body of the hyoid bone. And then there are two muscles, sternohyoid and thyrohyoid muscle. Sternohyoid muscle is attached to the upper part of the upper border of the sternum and takes insertion into the lower border of the hyoid bone. And sternothyroid muscle, which is a part of the sternohyoid, which is taking attachment to the hyoid bone, right? Sternohyoid and sternothyroid and omohyoid. These are three muscles that forms the boundary of the anterior aspect of the neck. Now, remember, since we are talking about differential diagnosis, if the swelling is coming from the submandibular region, it is a swelling from the submandibular gland. It is assumed. If a swelling is coming from the submental region, it is assumed to be submental lymph node. If a swelling is coming from the posterior triangle, in posterior triangle, the most important structure are the lymph nodes. So any swelling in the posterior triangle is a lymph node swelling. So by just looking at from where the swelling is located, you can immediately have a broad idea about the differential diagnosis of the swelling in a real patient. So patient को देखते ही you will understand कि कौन सा area से swelling आ रहा है, और from that itself you have a great clue कि this must be a this type of swelling. So if you have a swelling in the submandibular region, it's probably a submandibular gland swelling. Again, not entirely 100% correct, but probably. If you have a swelling in the submental region, it must be submental lymph nodes. If you have a swelling in the parotid region, it must be the parotid glands. If you have a swelling in the posterior triangle, it must be posterior triangle lymph nodes, some pathology of the posterior triangle lymph nodes. If you have a swelling in the anterior triangle or the visceral triangle, as we shall see, it is probably a swelling related with thyroid. So these are the 4 or 5 most common differential diagnoses of the neck swellings. If you want to summarize my today's lecture, this is the summary of my today's lecture, right? If you just want me to complete today's lecture in 5 words, this is what I will say. If you see a swelling in the submandibular region, it is submandibular gland. If you see a swelling in the submental region, it is submental lymph nodes. If you see a swelling in the parotid region, it is parotid gland. Very simple. If you see a swelling in the anterior triangle, it is probably thyroid. And if you see a swelling in the posterior triangle, which doesn't have much of visceral structures, it has only nerves and lymph nodes, so it is probably a lymph node swelling. Again, I'm not talking about rare things, I'm only talking about the most common pathologies. So here is what the triangles are. So you have the submental triangle, which is bound by the two anterior belly of the digastric, and then you have the submandibular triangle, which is bound by the anterior and the posterior belly of the digastric, and then you have the visceral triangle, which is bound by the omohyoid muscle and the sternomastoid muscle, and then you have the carotid triangle, which contains the carotid artery, which is behind the muscular triangle, also called visceral triangle. Again, you can recap the anatomy. Here is the posterior triangle, which is divided into 2 triangles. The upper part of the posterior triangle is called the occipital triangle, and the lower part is called as supraclavicular triangle, also called omoclavicular triangle. Old books will call it omoclavicular triangle. So this is what it looks like, and it's divided by the omohyoid muscle. So what are the contents of the submandibular triangle? Because a swelling from the submandibular region will be a submandibular gland, if unless proven otherwise, but it can be other structures also. Like in a rare example, it can be an aneurysm of the lingual artery, it can be an aneurysm of the facial artery, it can be an aneurysm of the facial vein, it can be an aneurysm of the lingual vein, or it can be tumor of the lingual vein, it can be an aneurysm of the superior thyroid vein, it can be an aneurysm of the retromandibular vein, it can be a neuroma of the marginal mandibular nerve, and it can also be a neuroma or a schwannoma of the hypoglossal nerve. These are rarer differential diagnoses, but most probably it is a submandibular gland swelling, right? But it can be any of these structures, because all these structures are present in the submandibular triangle. So you have to remember also important points, a surgical anatomical point is that when you are removing the submandibular gland, you are always at risk of injuring the marginal mandibular branch of facial nerve and hypoglossal nerve. So please remember this point along with this applied anatomy, that these 2 nerves are at great risk while removing the submandibular gland. So you should know how to locate and preserve these 2 nerves, especially when you are operating on a submandibular gland for a calculus or a tumor. Again, submandibular itself will take a full lecture, so I'm just telling you very briefly. Now, what is visceral triangle? Again, differential diagnosis of a swelling in the visceral triangle. So by far, I told you the swelling in the visceral triangle is a thyroid swelling unless proven otherwise. So if you see a swelling in the anterior triangle, it is a thyroid swelling. This is the differential diagnosis will be a thyroid swelling. दूर से patient को देख के ही बोल सकते हो इस patient को thyroid swelling है probably, because it's a swelling in the visceral triangle. So this is a broad view, right? but it can be other swellings also. It can be a parathyroid swelling also. Why not a parathyroid adenoma or even a parathyroid carcinoma? It could be a laryngocele coming from the larynx. It could be a tracheocele coming from the trachea. It could be something related with the inferior constrictor muscle. It could be a tumor of the esophagus even, and it could be a aneurysm of the inferior thyroid artery, or a neuroma of the recurrent laryngeal nerve, or a neuroma of the external branch of superior laryngeal nerve. Again, these are all rare differential diagnosis. 99% of the time, a swelling in the anterior triangle, as I told you before, is probably a thyroid swelling. So that is why I put it as number 1. So let's look at the epidemiology of neck swellings. Again, this is a broad outline. In children, most commonly neck swellings are inflammatory. So in a child who has a neck swelling has probably some form of infection or inflammation. An elderly patient who comes with a neck swelling has most likely a malignancy. So this, please put in your mind, please write it down, please keep this adage, keep this is rather a rule. Any swelling you see in a child is probably inflammatory and benign. Any swelling you see in elderly patient more than 40 years of age is probably malignant or probably some form of neoplasm. So if you see the incidence, most commonly here it's given neoplastic or even malignant. Elderly patient, it is malignancy. Younger patient, it is inflammation. Even in young adults, mostly it is inflammation. And inflammation can be an acute inflammation or it can be chronic inflammation like tuberculosis, right? So if you see a young patient with a neck swelling, think in terms of non-malignant things like inflammation and tuberculosis. If you see elderly patient, think in terms of neoplastic things like tumors and malignancy. Okay, so since we are talking about neck swellings, we begin with looking at the most common swellings, those that can occur literally anywhere on the human body, right? So these are swellings that can happen in any part of the human body and they can happen in the neck also. These are sebaceous cyst, lipoma and neurofibroma. 3 most common skin tumors, right? Skin swellings. So sebaceous cyst, lipoma and neurofibroma. So these swellings can occur literally any part of the body except palms and soles. These can occur in any part of the body, but they have a tendency to occur in certain places. Sebaceous cyst especially is very common in scalp region or in the nape of the neck. It usually doesn't occur on the face or on the anterior aspect of the neck. So it has a predisposition to involve the scalp and the nape of the neck. So why sebaceous cyst is common in the scalp? There is a story that, not a story exactly, this is what it is. When people are using a comb, usually they will injure the sebaceous duct and then there will be a sebaceous cyst formation. So that is the reason why sebaceous cysts are also particularly more common in the scalp, because people use a comb and they brush their hair, they rub their hairs and they accidentally injure the duct and then it gets blocked. And once it gets blocked, the sebaceous material collects inside the sebaceous cyst and forms a cyst, and this cyst is usually attached to the skin. So important cardinal feature of a sebaceous cyst is you will not be able to pinch the skin separately from the sebaceous cyst. Very important point, right? You will not be able to pinch the skin separately from the sebaceous cyst. It is attached to the skin. And also because it's a duct problem, there is a spot, there is a place where the sebaceous cyst opens naturally, and that place is a black spot which is called a punctum. So if you see a punctum and the skin is not pinchable and the swelling is semi-solid to liquid in consistency, it is probably a sebaceous cyst. Very simple, and very commonly it will occur in the nape of the neck, the back side of the neck and the scalp. These are 2 regions where it occurs. Other places it occurs frequently is the or skin over the testis, right? It's another very common place for sebaceous cyst to occur. Also it is linked with dandruff, right? So sebaceous cyst is also linked with dandruff, which is also a problem of the sebaceous glands, right? So sebaceous cyst, very common cyst and very common, but usually follows some injury to the scalp using a comb or something. Lipoma can occur any part of the body. The important sign about lipoma is that usually lipoma is under the skin, so skin will be pinchable, but lipoma has a very characteristic rubbery, fat-like feel, which is called the slip sign. So if you try to press the lipoma, it will seem to slip away from your hand, and the swelling is semi-solid to solid in consistency. Neurofibroma again usually occurs in the cutaneous nerve divisions. You can always move the neurofibroma horizontally. You cannot move the neurofibroma parallel to the direction of the nerve, right? And neurofibroma is usually a little bit harder. It is soft to hard in consistency. And there is usually some other neurofibroma in other places. If you ask them, do you have stigmata of neurofibromatosis, you will find them that they have other neurofibromas in other parts of the body. And so this is particularly common in a condition called type 1 neurofibromatosis, which is autosomally dominant inheritance. So now you can differentiate between these 3, right? So punctum, skin is not pinchable, it is sebaceous cyst. Slip sign, and soft in consistency, it is lipoma. Somewhat hard to firm in consistency and found in the direction is called direction of the nerve. It's called neurofibroma. Again, let's look at the lymphadenopathy. Lymphadenopathy is one of the 99% causes of the neck swelling. So lymphadenopathy, acute infections, acute lymphadenitis usually follows a viral infection of the throat or something, or tonsil. So acute infections of the lymph nodes is common, especially in children, and acute enlargement, and the lymph node will be tender, and the patient may be febrile, and patient may have other signs of viral infection, right? And other infection like chronic infections like tuberculosis. Again, tuberculosis, you have to look for tuberculosis in the lung, right? And then primary tumors of the lymph node, which is lymphoma, and then the secondary tumors of the lymph node, which is metastasis. I'll be a little bit more detail about this in the coming slides. Right. So what are the differential diagnosis of a midline swelling? Most of these swellings are not in the midline, they are on the side. If you find a swelling that is almost in the midline or strictly confined to the midline, you have to think in terms of a sublingual dermoid, which is usually seen in the submental region, a thyroglossal cyst, which is seen in the anterior triangle, and a laryngocele or a pharyngocele, which is seen in the anterior or visceral triangle. And important thing about pharyngocele or laryngocele is if you touch it, there will be a gurgling sound or gurgling noise. Okay, and the swelling may increase when the patient is asked to do a Valsalva maneuver. Laryngocele or pharyngocele is particularly common in people who do blow percussive instruments like shahanai and all, right? Lateral swellings, again, lateral swellings are parotid swelling, submandibular swelling, I already told you, branchial cyst, carotid body tumor, carotid aneurysm, carotid tortuosity, cystic hygroma, and subclavian aneurysm. So I'll be talking a little bit more detail about all this. Yeah, there's an interesting rule when it comes to differential diagnosis of the neck swelling, and the rule is called the rule of 85. What is this rule of 85? Is that when you have a non-thyroid neck mass, okay, non-thyroid neck swelling, the swelling is not thyroid, then 85% of the swelling is neoplastic and 15% is congenital or inflammatory. And in that neoplastic, 85% are malignant. So look at it, almost most of the time you are looking at only malignant swelling of the lymph nodes. And of those malignant tumors, 15% are primary tumors like lymphoma or salivary gland tumors. 85% of malignancies are mostly primary malignancy and primary cancer, and 15% are secondary cancers. So 85% are malignant, and of that 85%, 35% are neck primaries, and 15% are below clavicle secondaries. Okay, so let's look at how do you go about if somebody is presenting with a neck swelling, right? Somebody is presenting with a neck swelling. What are the investigation you do? Ultrasonogram and FNAC are the two main first step investigations. In fact, without hesitation, suggest a patient for going an ultrasonogram and FNAC. One through ultrasonogram will help you making a diagnosis of many of the neck swellings, right? Immediately arrive at a diagnosis of many of the neck swellings, like thyroid, for example. And FNAC will also help you make a diagnosis of many of the neck swellings. Only rare tumors you will not be able to make a diagnosis. There is a concern that if it's a malignant tumor, when you do FNAC, you are allowing the cells to spread. But studies and literature, extensive studies have indicated that there is no harm in doing an FNAC. There is literally no harm in doing an FNAC. You are not going to allow the tumor to spread, even if it is a malignant tumor, because the amount of material removed in FNAC is very small. There is very little chance of the tumor spreading through the FNAC tract and becoming systemic. So bindas, you write FNAC and ultrasonography of the neck. These are the two main workhorse investigations for making a diagnosis of somebody who has a neck swelling. If the diagnosis is unclear on FNAC or ultrasonogram, then better you do an excision or an incision biopsy. And neoplasia, if you have a supraclavicular lymph node, you have to think in terms of abdominal malignancy or stomach malignancy, as we see in the coming slides. So when you have an enlarged neck swelling, first imaging modality you do after ultrasonogram is the contrast enhanced CT scan, right? Granger's textbook of radiology, which I have consulted for making this slide, the credit goes to Granger. Granger says that contrast enhanced CT scan is the first line imaging modality to evaluate an adult patient with the neck mass of uncertain etiology. When you are not sure of the diagnosis, you are finding a swelling, but you are not sure what it is clinically, the best investigation to do is a contrast enhanced CT scan. And the most common node to be enlarged is the jugulodigastric node, which is also called the sentinel node. It is also called the nodes of Wood. So also called the tonsillar node, right? So these are got many names. The jugular-digastric node is also called a sentinel node. It is also called tonsillar node. It is also called nodes of Wood. So these are the nodes that are usually enlarged, right? And if you do a contrast enhanced CT scan, many times the radiologist can identify a primary origin of the secondary tumor. The best next investigation that is needed when you are not able to arrive even a conclusion with CT scan is to do a whole body fluorodeoxyglucose positron emission tomography fused computer tomography, that is PET scan. So best investigation to do is a PET scan next. And PET scan will help you delineate, as we shall see in the coming slides, will help you solve the problem of finding the primary tumor. If you are getting a secondary and you're not sure where is the primary, or you are not sure how much is the secondary, you may see one node, there may be 10 nodes hidden beneath that. So if you want to delineate how much it has spread and about the prognosis of the patient, the investigation to do now is your PET scan. The de facto investigation for neck tumor is PET scan. But you can't just PET scan right away. The problem is that, one, it is very expensive. Two, it involves a lot of radiation to the patient. It involves radiation to the patient. Patient has to undergo CT scan first. Then that image has to be fused with PET, and that then dye has to be given. It takes a lot of time to image, and it is very expensive. And there may be waiting time. If you are not in India, but in other countries, there may be even waiting time for getting the PET scan done. So you can't waste time waiting for PET scan. So you better do a contrast enhanced CT scan, which can be easily done on the day's notice, right? But the best investigation to do is a PET scan, positron emission tomographic scan. Why? It will help you delineate all the metastasis, all the primaries, right from the head to the toe. This scan is not done for neck alone, it is done throughout the body. So even if the primary is there in the stomach, you will be able to localize the primary and understand that the primary has spread and the secondary has occurred in the neck. Another investigation that is coming up is your MR diffusion imaging, dynamic contrast enhanced MR perfusion, and dual energy CT scan. These are the few new investigations that are coming up for making a diagnosis. I'm going to talk about some of the new investigations that are available, which is also a part of your paper. I think paper 4 is the recent advances in ENT. So in that you have to know and write about things that are recent in ENT. So MR diffusion imaging, dynamic contrast enhanced MR perfusion, and dual energy CT scan are newer modalities for diagnosing of neck swellings. Okay. One thing I had very interesting going through textbook of Granger is that what is the $1 million question that patient or radiologist or anybody is going to ask if you see an enlarged lymph node? Is this lymph node harboring malignancy? Is it a malignant lymph node or it is an infectious lymph node? Granger says this is one of the most difficult and most important question to answer in head and neck imaging, right? It's in fact a very difficult question to answer whether the lymph node is harboring malignancy or why this lymph node is enlarged. We can say the lymph node is enlarged in CT scan, but we cannot say that whether it is harboring malignancy or it is just a reactive lymph node that is enlarging due to some infection in the tonsil or the pharynx. So he says the clues are, if there is a cystic node, if you find that the node has become cystic, think in terms of papillary carcinoma of the thyroid. If you have a necrotic node with a thick enhancing capsule, think in terms of malignancy of the tonsil or tongue base. If you have a uniform enlarged node, think in terms of lymphoma. And if you have microcalcification and intrinsic bright T1 signal, think in terms of papillary carcinoma of the thyroid or thyroid carcinomas. So this also gives a clue, right? CT scan gives a clue that regarding the texture of the nodes. So if the nodes are uniformly enlarged, as we shall see in one more slide, that it is lymphoma. Another new investigation that is now available for making a diagnosis of neck swellings and malignancy especially is image enhanced contact endoscopy. Contact endoscopy is where the endoscope is no longer kept at a distance from the mass. In fact, usko chipka dete endoscope ko tissue ke paas, and then the photograph is taken, and you can see a lot of vascular loops. And there is a way of reading those contact endoscope. They say if you see a lot of vascular loops on contact endoscope, it is a sign of malignancy. So this is actually a cancer tissue you are looking at via a contact endoscope. So contact endoscopy is new modality of making a diagnosis. One other new modality that is available is optical coherence tomography, narrowband imaging. So narrowband imaging is a way of throwing light on the tumor. So through narrowband imaging, you can see that this tumor is appearing whitish. It's probably malignant. So you can see the tumor separately, whitish, and that is probably malignant. Okay. So let's look at some of the common tumors or swellings in the neck. Again, this is a very comprehensive lecture. I will not be focusing on any one. I'll just talk in detail. I'll not be going into detail each one, because each one, for example, lymphoma of the head and neck itself deserves a full lecture. So I'll just give you a brief outline. And at the end of the session, if you have any doubts, you can ask me. If you want any explanations, or if you felt that you didn't understand, you can always ask me to re-explain what you didn't understand, right? So let's start. So this is a swelling which was found in a small child. As you see the picture, it's a child with a swelling at the jugulo-digastric node. That is your node at the angle of the mandible. So when you take a CT scan, contrast enhanced CT scan, you find that there is a homogeneous tumor, homogeneous swelling of the jugulo-digastric node. The node is homogeneously enlarged. If you palpate the node, you have a characteristic rubbery feeling. So if you palpate the node, you get a characteristic rubbery feeling, and you do a CT scan, you see a homogeneously enlarged node. The diagnosis is a lymphoma. If you do a FNAC, you may be able to see the cells, and if you do excision biopsy or incision biopsy, you can immediately come to the conclusion of a lymphoma. The pathologist will tell you it's a lymphoma and what type of lymphoma. Rett-Steinberg cells, you know whatever type of lymphomas, it's the Rett-Steinberg cells dikhenge, and the pathologist will be able to tell you it's a lymphoma. So lymphoma characteristic is, again, differential diagnosis, angle of the mandible swelling or posterior triangle swelling, and the swelling will be usually rubbery in consistency. Sometimes it is hard in consistency. I've burnt my finger. I want to tell you a practical real story that happened with me. I had a patient who had a posterior triangle swelling, and this patient was living in a far village, and he had gone to the doctor, local doctor, and the local PEC doctor had thought the swelling to be tuberculosis. He started on ATT. He completed the ATT, but the swelling did not regress, which is very suspicious, because usually the swellings will regress. So मेरे दिमाग में तो चल रहा था कि it is a resistant bug, it's a resistant tuberculosis bacillus. So I immediately did all the tests, and it came off. FNAC kiya. FNAC was non-conclusive. It was completely fibrosed. Then I decided, let's do an incision biopsy and see, because it's such a big mass, it's not possible to excise. I said we'll do an incision biopsy and see. And to my surprise, it came as non-Hodgkin's lymphoma. It came as non-Hodgkin's lymphoma. It was not tuberculosis at all from the beginning itself. He was on the wrong line, because it's such a big node, and in the posterior triangle, actually everybody was thinking it is it's a tuberculosis. The patient was going on receiving treatment, and the swelling was firm to hard in consistency, which is a very important clue for malignancy. And it's an elderly patient. If it was a younger patient, I would have thought of lymphoma, but it was an elderly patient. Luckily, I was the one who made the diagnosis. I took an incision biopsy. It was proven that he had a non-Hodgkin's lymphoma, and I referred him to a higher center, hematology center, for taking further treatment. So let's look at what are the pediatric neck masses, right? So most important pediatric neck mass is acute lymphadenitis. Second is your thyroglossal cyst. So acute lymphadenitis and thyroglossal cyst account for around 90% of the neck swellings. The rarer swellings are thyroid swelling in a child, salivary gland swelling, branchial cysts, tuberculosis, cat scratch disease, toxoplasmosis, brucellosis, and tularemia. Yes, let's look at thyroglossal cyst first. So our thyroglossal cyst is a remnant of the thyroglossal duct, or that's why it's called thyroglossal duct cyst in many books. So thyroglossal cyst is a remnant of the thyroglossal duct, and thyroglossal duct is the one that forms the thyroid gland. It descends down, and then it splits into two and forms the two lobes of the thyroid gland. It begins at the foramen cecum of the tongue, and then it comes down. Right? During its process, it passes through the body of the hyoid bone and descends down into the anterior triangle of the neck, anterior visceral triangle of the neck, and then it becomes the thyroid gland. So if this duct persists, or a part of this duct persists, it leads to a cyst called thyroglossal cyst. And thyroglossal cysts are very common between hyoid and the thyroid cartilage. Almost 60% of the thyroglossal cysts are found between the hyoid and the thyroid cartilage. The next common causes sites are above the hyoid, which is called suprahyoid, and very rarely in the base of the tongue. So it can present as a tongue swelling also, very rarely, but it can present as a tongue swelling. You may think of a sublingual dermoid, but actually turns out to be thyroglossal cyst. So treatment is nothing. You have to just excise it, right? So you have to just excise it, and the name of the operation is called cyst trunks operation. Without going into details, I'm just telling you the name of the operation is cyst trunks operation, and second operation is Dunhill's modification of cyst trunks operation. Just one word about Dunhill's modification is that if you leave off the suprahyoid portion of the duct, that is called Dunhill's modification of cyst trunks operation. What is the difference between cyst trunks and Dunhill's? Is that Dunhill says that The suprahyoid portion anyway is atrophied. The infrahyoid portion is only important. So you trace that track till the hyoid bone, and then you leave the suprahyoid part. This is called Dunhill's modification of cyst trunks operation. I am not going to go talk about treatment at all, but remember. So how do you make a diagnosis of thyroglossal cyst? It is a swelling that will move up with tongue protrusion. Hallmark finding, okay, gold standard finding. If you find a swelling that is moving up with tongue protrusion and also with deglutition, the diagnosis is thyroglossal cyst unless proven otherwise. Okay, so these are swellings that usually will move up with tongue protrusion. They will also move up with deglutition. Whenever patient swallows, so patient ko bolo tukki, swallow the spit, and you will find that the swelling is moving. And you will also find that swelling will move up with tongue protrusion. Thyroglossal cyst is the most common cyst or most common thing that moves up with these two maneuvers. A thyroid swelling will move with deglutition but will not move with tongue protrusion. Okay, that is the classic teaching. Okay, that's the classic teaching. So thyroglossal cyst, cyst-like swelling in the anterior triangle above, below the hyoid bone, that moves up with deglutition and moves up with tongue protrusion is a thyroglossal cyst, especially in a young adult. Treatment is cyst trunks operation. Next coming the next congenital swelling is cystic hygroma. Now cystic hygroma is usually congenital swelling. Luckily, if for a child like this, sometimes it will regress by itself, so that is a good news. But sometimes it will present and it will persist. So it is basically a lymphatic cyst. So it is full of lymph fluid. It's full of fluid. It brilliantly transillumination. There is brilliant transillumination and is usually present from the birth. So cystic hygroma. So as the picture shows you of a child who has a massive cystic hygroma of the neck. So this child was born with an exit procedure. Another important swelling is the mucus retention cyst at the floor of the mouth, what is called a plunging ranula. So you can see the mucus retention, one part of the ranula underneath the tongue, the other part in the submandibular region, right? The two swellings like a dumbbell, they are connected to each other and they are filled with some bright fluid, and if you put torch on it, they brightly transilluminate because it's a mucus retention cyst. And the word ranula means a frog, right? The word ranula means a frog. So it seems as if there is a frog underneath the tongue, right? And the patient also has some funny voice. So maybe that is the reason the name has ranula is there. So it looks like a frog under the tongue, right? So that's why it's called a ranula. It looks like a belly of a frog, right? Basically. And also the swelling is transilluminant like a belly of a frog. So if you have the rainy season, you can see the frog making, the belly of the frog swollen. The male frog sits and makes some noise, and that you can see its belly, ballooning up, and it looks like that. That's why it is called a ranula. Ranula means in Latin means a frog. So it looks like a frog underneath the tongue with its big, transilluminant structure. And there is one more part which is the submandibular gland. That's why it's called plunging ranula. It plunges down into the submandibular gland, submandibular triangle. So plunging ranula. Treatment is excision. Another swelling, again I'm going to be fast and brief. Another swelling which is commonly seen, not commonly seen, is your branchial cyst. Now branchial cyst is the persistence of the second and third or fourth pharyngeal pouch, right? And the branchial cyst usually is seen in connection with the anterior border of the sternomastoid, right? Sternomastoid muscle. It is usually seen here, even in this, the swelling is, the redness is there in the anterior border of the sternomastoid. The swelling will be seen in the anterior border of sternomastoid usually. And the swelling has two parts, one that opens in the near the anterior border and usually in the upper two-third of the sternomastoid, and there is an inner part. So it's basically fistula. The inner part opens somewhere in the inside of the neck, inside of the pharynx. And if it is a second pharyngeal pouch fistula, which is more common, it usually opens near the tonsil, as the first picture shows. You can see the swelling is limited to the tonsil. Sometimes, if it is a third or fourth pharyngeal pouch remnant, it will open in the pyriform fossa. So these are the two places where this branchial cyst will open inwards, okay, and outwardly it will present as a swelling near the sternomastoid. So how do you treat? You basically do a step ladder excision, what's called a step ladder operation. You basically do a step ladder operation and you trace the fistula and you remove, right? If it is near the tonsil, it's usually opening near the supratonsillar fossa, right? Or crypta magna, somewhere near the crypta magna it will open because that's your second pharyngeal pouch. And if it is a third or fourth pharyngeal pouch, which is rarer, it will usually open in the pyriform fossa. Another rarer swelling in the neck is the hemangioma. If you see a swelling that is pulsating and you palpate it and you feel that is pulsation and there is bruit, the swelling is probably a hemangioma, right? Another common swelling that is seen occasionally is your sublingual dermoid. It's a dermoid cyst. It is a sequestration cyst. So dermoid cyst is basically a congenital sequestration cyst. So dermoid cyst usually will be well encapsulated. It will contain all sorts of funny materials, like it may contain skin, it may contain hair. Okay, and when it is malignant, it is called a malignant teratoma. And more common one, which is a lymph node suppuration. You have the suppuration of the lymph node. Here you can see the suppuration of the jugulodigastric node. So, or the signal node, right? So you can see the suppuration of the jugulodigastric node. And then it is teratoma. When the dermoid is completely malignant, it is called a teratoma, rarer tumor like teratoma of the neck. Here you can see in the cross section, you can see skin-like structures, you can see teeth, you can even see cartilage-like structures inside in the slide. And even rarer causes like embryonal rhabdomyosarcoma. So these can affect the paranasal sinus, they can affect the ear. So this swelling, which was looking like an abscess, turned out to be an embryonal rhabdomyosarcoma. Okay, so these are all the tumors. Let's look at the abscess. So if a patient is presenting with a fever and a neck swelling, and you find that there is a swelling in the neck, and that's very tender, and that is very painful, and the patient is having high fever, and the history is not of more than few days, then you have to suspect in terms of abscess. So if you have an abscess, two investigation you do immediately is the sonography of the neck. So if you see a sonography of the neck, you will see what the first arrow points the there will be loss of echo. Okay, because it's an abscess, there will be loss of echo surrounded by region of increased vascularity, which is shown by the reddish coloration, right? Reddish coloration is a Doppler flow. So you can see increased vascularity surrounding an area of anechoic area surrounding by increased vascularity, which is classic of an abscess. And if you see a CT scan, you will find a ring enhancing lesion, right? You have a capsule which is enhancing and a central area which is not enhancing, which is dark, surrounded by an area of edema. So it is classic of submandibular or whatever there is abscess, submandibular or parotid abscess. Here is a submandibular abscess, and you can see the classic ring enhancing lesion. You can see the enhancing capsule, and then there is a central part which is not enhancing and surrounding by the edema, right? Edema and swelling. So this is what it is. This is what it looks like on a CT scan. This is what it looks like on a real patient. Parotid abscess. Okay. And remember, in parotid abscess, the pinna will always be, the lobule will always be lifted up, right? So lobule will be lifted up as seen in this case. If you look at closely, the lobule will always be lifted up in a parotid swelling. Okay. So this is one more swelling we are talking about. This is more of a spotter. You can see that the swelling is not very bright on T1. On T2, it is very bright and there is very sharp margin. And if you look at it very closely, it is very, very well encapsulated and it is found in the parapharyngeal region. So it's up for a spotter. The diagnosis is, I'll tell you, it is a pleomorphic adenoma. So the margin is very clear. It is in the parapharyngeal space and it is bright on T2 with a sharp margin. The diagnosis is pleomorphic adenoma and it's well encapsulated. So the same patient, you can see this is a protrusion of the tonsil and you can see a swelling near the angle of the mandible. So your diagnosis is very obvious. It's a pleomorphic adenoma, right? It's a benign tumor. Yes. Now is a very important slide. This is a slide that is going to help you make a diagnosis in a real patient. Is that whenever you see some form of nerve palsy, think in terms of a malignant tumor. That is the takeaway message of this slide. So what is this? You are seeing somebody with a facial palsy and a parotid swelling. Now think in terms of a parotid malignancy. Because benign tumors like the previous one I showed you, this one is not cause malignancy. This will not cause nerve paralysis, at least not early, right? Very late it may cause, but usually will not cause any nerve palsy because it's a benign tumor. It's only going to cause compression symptoms. But if you see somebody like this with a parotid swelling and a facial nerve palsy, think in terms of malignancy of the parotid. So this patient is probably malignancy of the parotid without even knowing about it. दूर से देख के बता सकते हैं this patient is probably having a malignancy of the parotid. I will say this patient is having a malignancy of the parotid because you can say their facial nerve palsy is there. If you find some nerve is palsied, see, for example, if you find that the vagus is palsied or the mandible nerve is palsied, definitely it's a case for malignancy because benign tumors usually will not cause any nerve palsies. And malignant tumors always will cause nerve palsies, right? So this is another benign tumor we are talking about. Classic MRI picture, white arrow. Brightest students can immediately spot. This is what is called salt pepper sign, and the salt pepper sign is seen in paraganglioma of the carotid, right? Paraganglioma of the carotid or carotid body. paraganglioma. Why there is salt pepper sign? Because there are multiple areas of vascularity, and that vascularity appears like holes in an MRI scan, and that looks like a salt and pepper appearance. And that salt pepper appearance classically you can see in the white arrow, and you can also see, the left one is a digital subtraction angiography. You can see intense tumor blush, right? What is called intense tumor blush. You can see the blackish coloration on the digital subtraction angiography. That is intense tumor blush, showing that it is a vascular tumor, a paraganglioma. And what are the special scans for paraganglioma? You can do 68 gallium dodetate scan, or you can do octreotide scan. Same patient, when you do octreotide scan, you can see there is an intense uptake of the octreotide or 68 gallium in this picture. That's showing up as a black area in the upper picture, and it's showing up as a yellow area in the lower picture. So you can clearly see this is clearly a paraganglioma. So special test scan is there for paraganglioma. Please remember this. It is 68 gallium and octreotide scan. These two investigations will immediately help you making a diagnosis. So treatment is excision only. Yes, thyroid. I'm not even going to talk about detail about thyroid, because thyroid itself is a C, benign and malignant tumors of the thyroid. So we'll keep thyroid for some other day. But if you see a swelling in the anterior triangle that moves up with deglutition and does not move on tongue protrusion, think in terms of a thyroid swelling. Next, I want to talk about is the lymph node metastasis or occult primary. You have lymph node metastasis, you have malignancy deposit into a lymph node. So if you have a malignant deposit, so this is a contrast enhanced CT scan. You can see level 1A and B nodes here. The level 1A nodes are submental nodes, and this level 1B are submandibular nodes. And the submandibular nodes and submental nodes are separated by the facial vein. You can see the facial vein here as I have marked it. So these are two separated entities. And then you can see the enlargement of the submandibular and submental nodes. These are probably malignant nodes. Why? We'll talk in the next slide. This picture is taken from Granger. Okay. Yes, coming back. So now this is again a spotter. This one is also a spotter. Same findings, both CT scans. You can see the node is enlarged. It is very heterogeneous, and there is irregular enhancement, and there is central necrosis. Here it is very clearly seen. You can see something blackish, right? And that blackish part is the central necrosis. And you can see the node is enlarged. It is enhancing because it's looking more bright whitish. It is enhancing after giving contrast. And you can see there is a blackish central necrosis. This is hallmark of secondary metastasis. This is hallmark of a cancer inside the lymph node. So let's talk about a very important topic, a topic that is repeatedly asked in your examination, a topic that is repeatedly discussed. They asked me this question in my approval interview last month. Okay, so they are asking this again and again. Occult primary lymph node, very important topic for your final examination, very important topic for Viva, very important topic for your OSCE, very important topic for your theory paper. Occult primary lymph node, very long question. In fact, it's a long question. So occult primary lymph node. So with that primer, we begin the occult primary lymph node. Occult primary lymph node is when you have a lymph node enlargement without knowing the primary. That is called your occult primary. You are seeing patient comes to you with a big node and you have no idea where the primary is. तुमको कुछ मालूम नहीं कहाँ है primary. Patient is coming with a secondary node and you left your wits end. Where is the primary? You're scratching your head. Where is the primary? Why must we know the primary? What's the fun of knowing the primary? रहने दो ना primary को. No, we can't leave it like that. Why? Because whatever treatment, radiation therapy you are planning, primary also has to receive treatment along with secondary. It may be a very small primary and the secondary may be very big. Mind you, ऐसा हो सकता है primary एक पिद्दा सा हो और secondary बहुत बड़ा हो. But फिर भी primary का भी इलाज करना पड़ेगा और primary को छोड़ दिया और secondary का इलाज किया तो फिर primary will start growing and then it will create a big problem for the patient. So primary and secondary both have to be treated at the same time with radiation therapy, with surgery, whatever. But you have to find where is the primary. And there are three types of occult primary lymph nodes. One is synchronous primary. A synchronous primary is when the primary and secondary, they are both diagnosed at the same time. Patient आता है dysphagia के साथ and you have a lymph node and you see that there is a malignancy in the piriform sinus. It is a synchronous primary. Metachronous primary. Metachronous primary क्या है? You patient comes with a lymph node swelling. You see that you are not able to make a diagnosis of primary, but after some time, patient develops the symptoms of primary, like dysphagia or something. Then you go and do an endoscopy, you find out that there is a malignancy in the piriform side. There is a hidden malignancy all along, or a small malignancy all along. So that is your metachronous primary. Initially, there is secondary. Patient comes to you with secondary. You make a search for it, and after some time, it doesn't happen at the same day or in the same month. After a few weeks, you find out that the patient is having a primary somewhere and you make a diagnosis. It is metachronous primary. I have seen metachronous primary. In fact, a patient of mine, tongue-based malignancy, secondary node, FNSC, squamous cell deposits in the lymph node, and then we search for the primary. We did CT scan. There was a suspicious lesion in the base of the tongue. Patient did not turn up for treatment. Many months went by. Now the patient has got a fulminant secondary, fungating secondary in the tongue. So that is your occult primary lymph node with metachronous primary lymph node, right? A metachronous primary. Metachronous primary is you have the primary and then you have the secondary, which is occurring after some time, right? Like this case, like this case of a tongue-based malignancy. And then there is something called cryptogenic primary. Cryptogenic primary is you are not able to identify primary at all, despite all your best measures, despite all your steps. You are not able to identify the primary. Then it is called a cryptogenic primary, hidden primary to the end. Okay, but they say sometimes that the primary undergoes spontaneous necrosis or maybe immune destruction, and it is completely destroyed, and the patient has a secondary, and the primary is vanished by the immune system. So then it becomes a cryptogenic primary. Occasionally, this is seen. This is a rare phenomenon. Occasionally seen in melanoma actually, where a spontaneous resolution is possible. In fact, somebody asks you which is the only tumor that is highly metastatic, highly dangerous, but has a rare incident of spontaneous resolution is melanoma. They say melanoma can spontaneously resolve. Okay, so there's something like that, right? Immune destruction of the primary tumor, secondary alone remains, and you are not able to identify the primary at all till the end, which will be called a cryptogenic primary. So how do you make a diagnosis when you have an occult primary? The most important investigation in this case would be a PET scan. PET scan is the most important investigation. In 1/4 of the patient, PET scan will be able to directly identify the primary when you are thinking about where is the primary. And the little bit of a problem is the primaries in the Waldeyer's ring. If you have a primary in the Waldeyer's ring, you have to think in terms of lymphoma or HIV related adenopathy. And if you have a primary in the if you have a secondary in the Virchow's node, that is a signal node, otherwise called a supraclavicular node, then the secondary, the primary tumor can be in any part of the body. Usually it is in the stomach or the lungs, but it can be in any part. It can be even prostate. So if you have a supraclavicular node, you can think about primary in any part of the body, which includes ovaries, stomach, and lungs. So these are the three most common sites of metastasis in the supraclavicular node. So if you have a supraclavicular node enlargement, think of searching through the whole body and think in terms of ovary, think in terms of stomach, think in terms of liver cancer. And one of the important prognostic factor which is recently understood is the human papillomavirus. Human papillomavirus is now directly implicated in development and prognosis and development and prognosis and treatment of malignancy of the head and neck. Especially P16 gene, expression of P16 gene is an important factor in the development, expression, radiosensitivity of the head and neck tumors, especially head and neck cancers. So remember P16 gene of human papillomavirus. So this is what it looks like. Most commonly, the metastatic node is the jugulodigastric node. And this is the configuration of the outer lymph nodes of the neck, the parotid, the submandibular, the jugular chain, the preauricular, the postauricular, and the occipital. These are superficial chain of lymph nodes. And remember, there are around 300 lymph nodes in the head and neck. There are 300 lymph nodes in the head and neck, and there are 7 levels. These are called Sloan-Kettering Memorial classification of the deep cervical lymph nodes. So I'm not going to detail. You already know there are 7 levels, and the 7th level is the anterior cervical node, right? Anterior cervical node, also called supraclavicular nodes. So there are 7 levels, and there are 3 levels along the sternomastoid, and the 4th level is in the posterior triangle, and the 1st and the 2nd level is the submandibular and the submental glands. So submandibular, submental 1, 2, 3 along the sternomastoid, 4 and 5 along the posterior triangle, and 6 in the 4 and 5 in the posterior triangle, 6 in the anterior triangle, and 7 is the supraclavicular node. So you have the complete description of the nodes, level nodes, and this is called Sloan-Kettering classification. Interestingly, there are total 800 lymph nodes in the human body, of which 300 lymph nodes are found in the head and neck, right? 300 lymph nodes, okay? And out of 800 lymph nodes in the human body, literally half of the lymph nodes in the human body are found in the head and neck region. So if you have a swelling in the head and neck region, you are probably dealing with the lymph node swelling. These are deep cervical nodes, as just we talked about. Again, So when we are talking about hidden areas, I just want to mention this because it's an important Viva question. Also an important short notes is the hidden areas of the head and neck, where it can harbor a small hidden primary, but the secondary may be very big. So important hidden area of the head and neck is your piriform sinus. Second is your base of tongue. Third is your vallicula. Fourth is your fossa of Rosenmuller, where you can find malignancy of the nasopharyngeal carcinoma, right? Malignancy of the nasopharynx, fossa of Rosenmuller, crypta magna or tonsillar fossa, supratonsillar fossa, undersurface of the epiglottis, apex of the laryngeal ventricles, subglottic region, and postcricoid region. These are absolutely the most important areas you must search for whenever you have a secondary lymph node patient coming to you with secondary lymph node. These are the regions you have to adamantly and vehemently search for. Malignancy will be usually hiding in one of these places. Okay, and there are some aphorisms like lingotonsillar sulcus, which is called coffin's corner, and these are also called surgeon's graveyard. These are also called surgeon's graveyard because this is where the surgeon will make a mistake of not finding. Of all these regions, the worst region to have a malignancy is the subglottic region, which is simply not seen even with an endoscope. If you put an endoscope, do you see a subglottic region? No, you don't. You don't actually. What you have to do is you have to make incision in the cricothyroid, insert the endoscope through the cricothyroid in the reverse direction. Only then you will see the subglottic region. What is called a gonioscope is needed to see the subglottic region. You need an angled scope to see the subglottic region. Very difficult to see the subglottic region. That is the most hidden of the hidden areas. But the malignancy of subglottic region itself is very rare, almost only 2% or 3%. So you are safe there. And this is important Viva question, important short notes also. So one another clue that helps you make a diagnosis is the presence of the lymph node. If you have a lymph node in the jugulodigastric region, malignancy probably is hiding in the oral cavity, oropharynx, nasopharynx, hypopharynx, or supraglottic larynx. So that is what is called echelon lymph node. So echelon lymph node itself may come as a short notes for you guys, or it can be asked in the Viva. What is primary echelon lymph nodes? Echelon lymph nodes are the first lymph nodes that drain that particular site. So malignancy of a tonsil, the echelon lymph node is a jugulodigastric node. So if you have a malignancy or infection of the tonsil, it is the jugulodigastric node that will enlarge first. That is the echelon node, first echelon node. Likewise, if you have a malignancy of the tongue tip, you will have enlargement of the submental node, or a malignancy of the lower lip or floor of the mouth, there will be enlargement of the submental nodes. If you have malignancy of the paranasal sinus or oral cavity or submandibular gland itself, there will be enlargement of the submandibular nodes. If you have a malignancy of the thyroid, you will have enlargement of the anterior triangle nodes. And if you have a malignancy inside the abdomen, usually breast, lung, stomach, or ovaries, you will have enlargement of the supraclavicular nodes. And interestingly and surprisingly, if you have malignancy of the fossa of Rosenmuller, you will have enlargement of the lower posterior triangle nodes, right? That is why it is called that is why it is marked here. The posterior triangle nodes will be enlarged because that's how they drain, right? They go into retropharyngeal nodes. So through the retropharyngeal nodes, the nodes drain into the posterior triangle nodes. So nasopharynx predominantly drains into the posterior triangle. That is why you have enlargement of the posterior triangle nodes. And if you have malignancy of the scalp or something, a basal cell carcinoma or something, there will be enlargement of the occipital nodes. So these are the echelon nodes of the head and neck, first echelon nodes of the head and neck. From this concept has emerged one more concept, which is called sentinel node biopsy. Sentinel node biopsy is that you give a dye into that primary area, and then you look for the areas where the dye has taken up, the radiotracer dye has taken up, and these are the places where you take a biopsy, and this concept is called a sentinel node biopsy. This is again when you are not able to make a diagnosis of primary or secondary, when you are confused, or you want to eliminate where are the places where it has metastasized, you can do what is called sentinel node biopsy. Yes, again same question, ring-like enhancement of the lesion along with within the posterior paraspinal neck muscle, it's probably an enlarged lymph node. Okay, I'm not going to go into detail of this. What are the imaging criteria of malignancy in the in a lymph node, right? So they say the lymph node has become more oval or round in shape. There is loss of fatty hilum. There is central necrosis. There may be calcification, and then there is heterogeneous enhancement of the lymph node. And the most important thing I repeat is that to FDP, that is PET scan, you can easily make a diagnosis of a lymph node involvement. And lymph node enlargement may be inflammatory. Because there is a malignancy, don't think that there is only metastasis. It's possible that due to malignancy, the nodes are reactive and the nodes are suppurative, or it may be a tumor deposit in the node. So it's very difficult clinically to make a distinction. If you have enlargement of the signal or virchow nodes, It is due to the malignant cell carried by the thoracic duct, and it is the primary is usually in the chest or the abdomen, as I said. And there is one more node called Rovier node, which is in the retropharyngeal region. I said nasopharynx drain into the retropharyngeal nodes, and the highest retropharyngeal nodes are called Rovier nodes. They are within the 2 centimeters of the skull base, and they are the site of spread of malignancy of the nasopharynx and esthesioneuroblastoma. Again, this is the picture shows you Rudolph nodes or Rudolph-Virchow's nodes or signal nodes, supraclavicular nodes. Posterior triangle swelling. You have a CT scan picture here. You have area of edema, capsular enhancement, central necrosis, multiple lymph nodes, and some calcification also. So the diagnosis is tuberculosis, scrophulodderma. So these are the stages of tuberculosis caseation, you already know, and the final stage is formation of a sinus or a cholesterol abscess. Okay, so this slide should have come before. What are the most common source of the occult primary? Nasopharynx, tonsil, base of tongue, thyroid, supraglottic larynx, floor of mouth, palate, and piriform fossa. And how do you make a diagnosis? You do pan endoscopy, also called triple endoscopy. Usme kya kya hai? Nasopharyngeal endoscopy, esophagobronchoscopy, and direct laryngoscopy. So this is what you should do. And sometimes you have a malignancy deposit in the neck from the other region, from the abdomen, usually lung malignancy, esophagus malignancy, breast and stomach malignancy. Towards my right, I am showing reticulate lichen planus. Looks very dramatic, but it is not malignant. It is a benign condition. So don't be frightened if you see something like this and say that this is malignancy. Looks very dramatic, right? So if you look at the slide, looks dramatic. That's why I put it here. It is not malignancy. It's a benign condition. It's the reticulate lichen planus. Patient will be having this since for many years without any symptoms or just minimum burning sensation. So now we put an important slide. You can see the PET scan, right? I was talking about PET scan all along. This is what PET scan look like. And you can see a bright signal at the tonsil region. And in the CT scan, I have marked it with a red arrow. And on the PET scan, you can see the bright signal. Immediately the diagnosis is obvious. It's a malignancy of the tonsil. Malignancy of the retromolar trigon. So if you retract the cheek, you see a ulcerative proliferative growth in the retromolar region. And if you take a PET scan, you can see a bright uptake of fluorodeoxyglucose in that region, bright signal, bright uptake of dye, fluorodeoxyglucose dye, and you can conclude that there is a malignancy in the retromolar trigon. And then there is a postcricoid region, another hidden area. Most of the time, postcricoid region is closed. So if you put an endoscope and see, there is a exophytic growth in the postcricoid region. Esophageal growth, they can also present with neck swellings. So this is growth of the mid esophagus. There is malignancy of the mid esophagus. You can see proliferative growth in the esophagus, mid esophagus, or you can even say ulceroproliferative growth in the mid esophagus, ulceroproliferative growth in the supraglottic region. And then this is the surprise thing. This is actually a malignancy of the nasopharynx on the right side, but it's completely occult. I put this slide from a classic textbook of oncology, Devita, I think. From Devita, I have taken this, how occult it is. This is a picture showing normal. We may easily dismiss this patient saying everything is normal. But blind biopsy of the right-sided fossa of Rosenmuller revealed that there is a malignancy. This is a patient who presented with a secondary lymph node, and blind biopsy of the right fossa of Rosenmuller revealed that there is a malignancy, or that is a right nasopharyngeal carcinoma hiding. So it's completely occult. No way of making a diagnosis. You may even tell the patient it's normal. You may go. Another thing, piriform fossa growth. You can see the bright signal in the piriform fossa, and you can see the bright signal in the metastasis. So before I conclude, I just want to tell you what are the areas of taking blind biopsy in a occult primary, or this is also called surveillance biopsy. So you have to do unilateral tonsillectomy of that side, and of course you have to do the biopsy of the tonsillar bed. You have to do biopsy of the base of the tongue. You have to do blind biopsy of the piriform sinus, of the subglottic region, of the fossa of Rosenmuller, of the adenoids, and of the retromolar trigon. So you have to see the echelon node, and you have to take a biopsy from all these places until you find catch the tumor, because all these areas tumor can be submucosal, it can be hidden. And this is a common viva question. What are the sites in the head and neck where there is bilateral metastasis? So lower lip, tongue, supraglottis, soft palate, and piriform sinus. These are the areas which have bilateral lymphatic drainage. So patient in tumor in any of these regions will have bilateral neck swellings. Thank you. I think I have given enough fodder for your thought. Now is the time. I will like to take some questions from you guys. Yeah. Hi there. Now is the time. I'd like to have some questions from the participants. Yes. What are the biomarkers? I already told you there are many biomarkers. P16, 4Q, 3P. There are many biomarkers. Loss of chromosomes, and there is a P16 I have told you, which is very common biomarker. The P16 is for human papilloma virus. But if you are looking at nasopharyngeal carcinoma, the biomarkers will be different. You have biomarkers for Epstein-Barr virus. So this is a very big question, Durga. I just can't answer it today. Maybe we will have a full half-an-hour lecture on, the biomarkers for head and neck. Putative biopsy is named as sentinel node biopsy. I think putative biopsy means surveillance biopsy I was talking about in the last slide. Can you tell me exactly the flow chart for occult metastasis? The flow chart is something like, it's the same as the lymphatic drainage, right? So I'll tell you flow chart, for example, of nasopharynx. The fossa of Rosenmuller, the nodes of the Rovier, the retropharyngeal nodes, the parapharyngeal nodes, and through the parapharyngeal nodes, the posterior triangle node. So this is the flow chart, it flows. And for if you're talking about stomach, then from stomach malignancy, it goes into the thoracic duct, the left thoracic duct, and comes to the supraclavicular node. So you can have flowchart of each malignancy. You can basically trace the lymphatic pathway, right? Lymph node persistent swelling after ATT complete management. Yes, very good question. I told you a story. It really happened with me. Lymph node swelling persisting after completing ATT management. This might be very suspicious. And I took an incision biopsy because swelling was very big. I was not going to exercise it completely. Such a big swelling in the posterior triangle. And it was in the posterior triangle, making a case for ATT. But yeah, better take a biopsy. I will strongly suggest you take a. Dr. Sonali Pradhan has asked me what to do if there is a sinus. Better you take a biopsy, madam. It's probably some form of malignancy, or in my case, it was non-Hodgkin's lymphoma. Biopsy only proved it. So you better take a biopsy and send it. If you can't take an excision biopsy, better do an incision biopsy. Manikali Rai is asking me, hello sir, blind specimen collected have to be done from all the set sites, mandatory to do from all the list. Now again, Manikala, I can't say that you do it from all the sites. Basically, that's why I said no, echelon node dekho. If you have the jugulodigastric node, then you probably are looking at a malignancy from the tongue. So tongue se nikalo pehle. Or if you are having a posterior triangle node, then you take it from the nasopharynx first. Got it? So you don't just blindly take biopsy from all the places. You use your brain. You see the echelon nodes. Where are the echelon nodes? If you have a submental node, so I will search for a malignancy in the floor of the mouth or the tip of the tongue, right? Or if I have a submandibular node, I'll try to look at the parotid or the tongue or the floor of the mouth. So you take the call, right? So that is why the echelon node is there. So you don't take just blind biopsy from everywhere. You just take biopsy first from the echelon places. But if you're still not concluding, if the pathology says I'm not seeing any malignancy, then you might have to take it from all the places, including from the bronchus. Yeah, any more questions? And Dr. Rawat, I will think we should have a full lecture on biomarkers of malignancy because it's a full topic. I think I cannot do justice in just in this lecture. If you have any more questions, I'll be happy to answer them right now. Can I do IND for tuberculous abscess? Yes, sir. Priyanka Dixit is asking a very important question of whether can I do an IND in a tuberculous abscess. So important thing you have to do is you have to first start ATT. So you may ask me, it's like egg out of chicken, chicken out of egg. When you do IND for material बेच के तो मेरे को पता चलेगा ATT है कि नहीं है. So you have to first confirm it is tuberculosis. You have to start ATT, give it some time, then you do an incision and drainage and do a non-dependent incision drainage, right? Don't do a dependent incision drainage. That is, don't allow it to, gravity to drain it. You do a non-dependent incision drainage, then it can be done. You take incision in the upper part of the tumor, right? Don't put it in the gravitationally lower part of the tumor. Make it an incision in the upper part of the tumor and you drain it through suction or some method. That is the way to do an IND in a tuberculous abscess. But you have to start an ATT if you suspect a tuberculous abscess. Without ATT cover, you don't do an IND. How long we have to wait for a lymphadenopathy with FNAC report as inflammatory with conservative MX? See, FNAC is almost 85 to 90% sensitive. If the pathologist is saying that it is inflammatory, it is probably inflammatory only. Very rarely only malignancy will be there. So it's up to you. Again, it's your clinical judgment. You can wait for a few weeks and see. Maybe you can give a course of antibiotics. Again, ask me the antibiotic. I will give ciprofloxacin or doxycycline or fluoroquinolones and doxycycline because that is the best treatment for lymph node enlargement. And I will give you a few weeks with this antibiotic therapy. If the swelling does not resolve, then I am left with my wits end how to make a diagnosis. You can do a PET scan. If nothing, you're not able to conclude at all, the best way to go for is the PET scan, which वो दूध का दूध और पानी का पानी हो जाएगा PET scan. क्यों तो malignancy is there, definitely it's going to be seen along with secondaries. Sir, I have itching in my throat regular basis. I consume cetirizine. What am I supposed to do? This question is not related to your topic on hand today. Itching in my throat can be due to many reasons. It can be due to reflux. It can be due to allergy. It can be due to chronic pharyngitis. There are many reasons why you may have itching in the throat. Better you take some don't take cetirizine. He's saying that he's taking cetirizine. Cetirizine is not a good medicine, mostly because it will cause a lot of sedation. So you can take some levocetirizine or some newer generation antihistaminics like fexofenadine, and you get an endoscopy done. Get an video endoscopy of the larynx done. Might be dealing with some form of allergic pharyngitis or maybe even reflux. So we have to rule that out. So this is my answer for the question that I consume cetirizine. What should I do? Sir, can you tell me the flowchart for diagnosis of unknown primary in Scott and Brown? Um, yeah, I basically told you. First, you do an Vishnu Priya. Basically, you do is you first do an ultrasonogram and you do an FNAC. If the diagnosis is still not clear, you go for a contrast enhanced CT scan. If the diagnosis is still not clear, you basically do an incision biopsy or excision biopsy. Still not clear, go for a PET scan, that is positron emission tomographic scan. That is your flowchart, right? You will find 99% of tumors in this pathology. Okay, so first is ultrasonogram, FNAC, not clear. Still next, you go for the next one, which is contrast enhanced CT scan. Still not clear. Then you can go for excision or incision biopsy, and or you can go for a positron emission tomographic scan. That's all. That's all your flowchart. You will catch 99% of your tumors by this flowchart I'm telling you. So I think Scott and Brown is same thing is given in a very complicated. What is the minimum size of lymph node from which FNAC can be done? See, any node that is palpable, pathologist will be able to pull some tissue out. So I will say ideally 1 centimeter more than 1 or 1.5 centimeters would be the minimum size of lymph node. Actually, ऐसा कुछ size ही नहीं है. If you are able to palpate the node, it's already more than 1 centimeters in size. Any clinically palpable node, FNAC can be done. Any clinically palpable tumor swelling, FNAC can be done. Not an issue. If you have an issue, Mridula, if you have an issue doing FNAC, you can ask the help of the radiologist. Ask the radiologist to locate the tumor and you take FNAC. That is also possible. Na? So you can team up with the radiologist and pathologist and take the guidance of the radiologist. He will tell you which part to take an FNAC in case you are having a doubt. Because some of these tumors, they can be heterogeneous. Like for example, tuberculous lymph node, it can be partly liquid, partly solid, partly calcification. So your radiologist will tell you kahan se material milega tum. So take the help of the radiologist if you are having a doubt. What is the minimum size? Any minimum size, any node that is palpable, you can do an FNAC. And Bashir wants to ask me, tell me bilateral metastasis question. Okay, bilateral metastasis kya hai? See, many parts of many organs are there. Now they are having bilateral lymphatic drainage. Pyriform fossa, for example, it's rich in lymphatics. So if you have a swelling or a cancer in the pyriform sinus, you will get metastasis on both sides. So patient may have a growth in the right pyriform sinus, but the patient will come with metastasis of both right and left lymph nodes. That is what it means, bilateral metastasis. So there are some places where there is bilateral drainage, like for example, tongue tip, pyriform fossa, epiglottis, supraglottis. Again, supraglottis has got rich lymphatics, so there may be bilateral metastasis, and nasopharynx also. Okay, so these are some of the places where there is bilateral metastasis. This is what I mean by bilateral metastasis. So you will be confused, right? दोनों side है तो कौन से side में primary हो सकता है? You will become confused. So that is what the importance of this is. And bilateral होगा तो staging will upgrade, right? You will directly go to stage 4 if there is a bilateral metastasis, right? So that is also staging. Also directly patient goes for stage 4, the terminal stage of malignancy, because the malignancy has now spread to both sides of the neck. That is the importance of bilateral metastasis patient. Any more questions? Sorry guys, if I am talking very fast. I have the habit of talking fast and a little bit unclear. Thank you for bearing with me. If there are any more questions, I will answer them. Otherwise, we'll wrap up today's session. Yeah, I think thank you very much. Thank you all for tuning in and asking such wonderful questions. Wonderful questions. So thank you. I just want to thank National Board of Examinations for giving me this opportunity. And I want to thank Navneet sir for giving this opportunity. Thank you very much. Thank you all. Thank you.
Dr. Santhosh.